We're going to go ahead and start our Child and Adolescent Psychiatry Grand Rounds. It is a great pleasure for me to introduce Dr. Barry Sarvet, who's the chair of the Department of Psychiatry at Baystate Health and professor and chair of the Department of Psychiatry at University of Massachusetts Medical School, Baystate. His career has focused on designing and implementing population health strategies for improving access to mental health care and disseminating evidence-based practices in mental health treatment. He serves as medical director of the Massachusetts Child Psychiatry Access Project, an innovative public system for improving access to care for children with mental health needs throughout the state of Massachusetts. This program has been instrumental to the successful implementation of universal mental health screening in the primary care setting for children across the state. Massachusetts Child Psychiatry Access Project has served as a national model for improving access to children's mental health treatment and has been replicated in 38 states. Dr. Sarvet has written numerous articles regarding integrated mental health care and has provided technical assistance for programs throughout the U.S., striving to develop systems of collaboration between psychiatry and primary care. His work has also been focused on addressing the needs of patients who have been impacted by traumatic stress. He has provided leadership for the Baystate Family Advocacy Center, a clinical and research program for patients who have been victims of abuse, domestic violence, and other forms of trauma. And in this setting, he has led series of federally funded projects for the dissemination and adaptation of evidence-based, trauma-focused psychotherapy models within community mental health settings. Dr. Sarvet is co-chair of the Healthcare Access and Economics Committee of the American Academy of Child and Adolescent Psychiatry and co-chair of the Mental Health Task Force for the Massachusetts chapter of the American Academy of Pediatrics. He's also the past president of the Western MA chapter of the American Foundation for Suicide Prevention. It is such a great pleasure to have you here today. We're very excited to learn more about your work and learn a few things or two from the work that you've done nationwide. Thank you so much. Please join me in giving a warm welcome to Dr. Barry Sarvet. Thank you for being here today.
Well, thank you so much, Dr. Stewart, for that lovely introduction. And it really is my honor to talk to your department. And I also want to give a shout out to Dr. Chuan Mei Lee, who is a person I have talked with and collaborated with in this work, around trying to develop models for improving access to care and trying to support her project. And so it's a pleasure to be here, and you guys have a wonderful department. So I think we can go to the next slide. I just want to make a note of my lack of commercial relationships. I have some federal funding and some state contracts and a nonprofit consulting relationship with the Meadows Mental Health Policy Institute. But that's it for me. And it shouldn't contaminate my presentation. So I like to start with a case just to sort of illustrate, some of this work. And so I'm just going to sort of bring up a teenager who is, we'll call Ryan. And he basically was found to have depression in the context of his medical treatment. Because a lot of the work that we're doing is all about trying to build a connection between medical systems and behavioral health systems. And so in this particular instance, he was being monitored for his diabetes by his PCP, and everyone was concerned about him. And because of some work that we had done, we really sort of are seeing very good compliance with using measurement tools in that particular practice. And so they screened him with a PHQ-A, and he showed moderate severity depression. And then they followed that up with an assessment, which again is not necessarily a universal kind of resource in primary care, but this particular practice has an integrated behavioral health clinician who assessed him and diagnosed and really made a formulation which included diagnosis of depression with occasional suicidal thoughts. You can go on the next slide. Next slide. Thanks. So this clinician began treating him in the primary care setting and worked with his parents. He actually improved, but he plateaued with still low, moderate, mild to moderate depressive symptoms. And this practice had access to the Massachusetts Child Psychiatry Access Program. They did curbside telephone consultation to think about what to do. And so therapy alone wasn't working. And according to our protocols and our best practice guidelines, we recommended adding an SSRI, pretty straightforward. And then he did better. And we sort of closed the loop, and he did well even at 12-month follow-up. So it's a fairly typical kind of story of what happens when there is kind of a really good collaboration, between mental health and primary care, where they're able to sort of catch sort of a mental health issue before people come in and into crisis, and they're able to initiate treatment and modify the treatment, as it goes along, which is a very important aspect of this. So next slide, please. So just a bit of background, and I will say I'm aware that you guys have a similar program in your area. I think with some of the help of some of the leadership that you have, including Dr. Lee and the HRSA funding that has been made available. But I'm also going to assume that not everybody knows about this program, so I'm going to sort of describe some of the basics of how these programs work. But the context of it is just that, as you know, I won't belabor this, but we have a massive workforce shortage, and we have a maldistribution as well as an absolute shortage of child psychiatrists. And the outcome of this is just that the majority of kids, either half or more than half of kids who have psychiatric illnesses, don't get the treatment that they need. And it falls on primary care. So primary care have been the default providers of mental health treatment without any training and without really any help, from us, in child psychiatry, that lots of prescriptions are being written and lots of recommendations are being made. And historically, the care is not always, optimal and consistent with best practices, and the care is not always coordinated. There's not always follow-up, but the pediatric community has really sort of been responsible for this as kind of the safety net or the default provider. Next slide, please. There it is. Yeah, so and if you click one more time, there's a little pop-up on that slide. There you go. So Robert Findling, a very prominent child psychiatrist, brought up the idea, in 2018, but it wasn't new, that our workforce really needs to be thinking about, how do we shift? It's really a task shifting sort of paradigm in the sense that most child psychiatrists that I know were trained to just treat kids. We're all always trained to collaborate and to have multidisciplinary models, but we're really trained, in the specialty care model. And it just doesn't fit, the public health, sort of arithmetic of all the need, for us to just exclusively as child psychiatrists be, just having a practice and treating kids and following them and working collaboratively with therapists in the mental health, sort of system, and that we need to kind of find a new way of practicing that involves helping other people to treat, these patients and not, just kind of saying that we don't have enough and so people have to go without. And so really it was a task shifting paradigm to address a shortage or a scarcity of resources. Next slide, please. So before we go into the CPAP model or the MCPAP or the collaborative kind of practice model with our program, I wanted to kind of situate it in the context of the different types of collaboration, because we're by no means, the only way that we, coordinate and collaborate with primary care. That there are several models. There is the behavioral health clinician model, which is also referred to as the primary care behavioral health model. And that's kind of where you have an embedded therapist, not a child psychiatrist, where the therapist is embedded in a practice. And the case that I discussed was one of those examples of having an embedded therapist. And actually that really demonstrates that these models are not mutually exclusive, that they can be kind of complementary to one another. So there is this, growing trend. I don't know how it is in California, but in Massachusetts, I think we've crossed the line to have more than 50% of the primary care practices in the state of Massachusetts have an embedded behavioral health clinician. And the role of the clinician in this particular model is really consultative. So if the patient is presenting, with a behavioral health problem, then they can get a consultation just like I described with the case. Some of the models include systematic screening and sort of evaluating people who are, detected, within the practice to have been suffering from a psychiatric illness. And so that's one model. Then there's the Child Psychiatry Access Program model, which is it's all, kind of population-based, regional, kind of remote sort of model, which leans heavily on telephone consultation, but also includes face-to-face evaluation and coordination of resources and things like that. And then I guess the third, category is the collaborative care model, and the terms are confusing because we use the term collaboration when we describe our CPAP programs, but the collaborative care model, which originated at the University of Washington, is a model where there is a combination of an embedded clinician in the practice. There is the use of measurement-based care, and there is the role of the psychiatrist in terms of doing consultation, primarily with the clinician, the therapist, but also with the primary care provider. And that model has lots of evidence behind it. One of the things about the CPAP, or the Child Psychiatry Access Program model, is that we're not a treatment. It really is more of a system for kind of connecting people to resources and providing consultation, but it's not sort of a treatment model in the way the collaborative care model is, where patients are identified, treated, and to a target using measurement-based care. So I would say I would say the collaborative care model is the closest thing to what I would consider to be a gold standard for how to really sort of provide the best care for patients, within the primary care setting. However, it's a very expensive model, and it's very resource intensive, and it's not sort of sustainable for a lot of places. As I mentioned in the case, we approximate sort of the same thing, with when we combine CPAPs with, this generic, more behavioral health clinician model. We can use measurement-based care. We can pretty much do all the same things that the collaborative care model does, but the standard CPAP model doesn't include all of those components. It really is focused on consultation and some resource coordination. Next slide, please. Just gotta keep in mind my clock here so I'm staying on time. Okay, so now I'm going to talk about CPAPs. So basically they're, by definition, I would say, they're teams, that are designed to help primary care providers to do the job that they have taken on, to really address mental health issues in the primary care setting, when people need them. And one of the essential aspects of the CPAP model is that it's a population-based system. So it's sort of a program that is provided for a geographic region and is meant to kind of meet the needs of all the children and practices in that particular region, at least, to the extent that we can. Next slide, please. So this is the landing page of our website, and the tagline of the program is connecting primary care with child psychiatry. And actually, I've said this in other contexts, but I kind of feel like the sort of essence, if you will, of MCPAP and CPAPs in general is that they're systems for the cultivation, or for the initiation and cultivation of relationships, that they're systems that promote the formation of relationships between primary care teams and child psychiatry teams. And so we do a lot of things, within that relationship, but it's really the relationship is the special, sort of sauce, of the program. And so if we don't sort of make that relationship kind of work, and we have to kind of troubleshoot it, it's not an easy relationship sometimes, but a lot of the work and the challenge of operating a PAP is really kind of troubleshooting and sort of promoting this formation of a relationship. And when it works, you end up with primary care practices that really feel as if they have all these friends, in the mental health world that they didn't have before, who can help them take care of their patients. And so that's ultimately the vision that MCPAP, has always had. Next slide, please. So the map is exciting, for us. The only states that don't have either a program that's established or a program that's in the process of being developed are 4 states, Idaho and Arizona and South Dakota and Ohio right now. And that's with we had a major sort of step forward with HRSA funding that started out with the 20th Century CARES Act and then went on to be continued with the American Rescue Plan. Next slide. I guess that slide is really meant to show that MCPAP and CPAPs have kind of become really a thing, that it's kind of like a whole career track for some child psychiatrists to include. We don't want actually psychiatrists to do this full time, because you gotta, sort of, it's not a very sustainable job to just do, that one thing. That we want all the psychiatrists with the MCPAP and CPAPs to have their hands in actual, direct treatment too, but to kind of carve out a portion of their time to do this kind of work. And right now in Massachusetts, we have 28 child psychiatrists who are actually involved in MCPAP, for a part of their job. We have about 6 FTEs, but 28 actual people. So the purpose, again, is defining what is primary care mental health, and what does it look like, and to support it, helping to identify, what the boundaries are, what patients are okay to stay in the practice, which patients are not and need to be seen by specialists, connecting the practices to the whole, behavioral health system. And actually, I have a typo in there. It's connecting primary care practice to the pediatric behavioral healthcare system, and then improving the quality. That we don't just want people to get some treatment. We actually would like them to get good treatment, that's consistent with best practices. And again, their systems of relationships. Next slide. So we're configured in Massachusetts with 3 teams. Each team has its own dedicated hotline. Each team is made up of several sites. Most of the sites are academic medical centers. And the sites are kind of where the face-to-face evaluations happen when we're not in the middle of a pandemic. In the context of the pandemic, all of the direct face-to-face evaluations have been done through telehealth. Next slide. So it's just a map and listing the different institutions, that have been involved, and also just the team composition. So it is a multidisciplinary program, and so it doesn't have just child psychiatrists, but we also have care coordinators who we're calling resource and referral specialists, and behavioral health clinicians who are doing some of the work. Next slide. So the flow of how the program works is that everything starts with a question, that we're waiting for primary care providers to ask us for help, which is actually one of the limitations of the program because people don't always know when they need help. But in any case, the way the system works, as a standard or the general process, and there are exceptions to this, is that people would call a hotline, and anyone within the practice, but primarily the primary care provider or a clinician in the practice would call a hotline asking for help or having a question. They would be directed to either a child psychiatrist, a therapist, or a care coordinator, depending on the nature of the question. The question is about services, for example, or how can I find this particular type of service for my patient? Then it would go to the care coordinator. If the question is about diagnosis or what, I'm not sure, how to sort out what's going on clinically, then it would usually go to a child psychiatrist. If the question is more about family dynamics and things like that, it might go to the child therapist on the team. And then if you move to the right, each of these things can be escalated. So if we can't answer the question, then we can see the patient, and that's where the direct services come in with face-to-face therapy. And then if the care coordinator really needs to do more, then they can provide direct resource navigation to the family, by talking with the family about, what their needs are and what some of their preferences are, and trying to get them an appointment, help them to get sort of something. So next slide. So we mentioned these different functions, the telephone consultation, answering questions, talking with people on the phone, seeing the patient, doing resource navigation. We also are kind of delivering more formal educational resources because we recognize the knowledge gap, for pediatricians who haven't received the training that they really need. And so we provide training in different modalities through our program. Next slide, please. So I want to sort of just go through each function a little bit. I think I'm going to breeze through that quickly because I want to get to some other things. But the telephone consultation really is the most prevalent, the most frequent service that the program provides. And it really is kind of call it the engine of the CPAP, because all the other services and the relationship building that goes on is sort of going on through as many as possible conversations that we try to keep brief, because the pediatricians, their workflow requires that these be brief conversations that we would ordinarily be happy to talk with them for a half an hour or an hour, about, because all their questions kind of can go pretty deep. But that's not what they want. They want something quick, but we want to do a lot of them, because the more conversations we have, the more the relationship builds up over time. And then they learn, through incremental, sort of interactions, so the design of the program is really designed to make, that access to a telephone consultation to be very low threshold, so people can just call a number, get through quickly to a child psychiatrist, have a brief conversation, and then move on. And that allows us to have more of them, and to have the relationship be developed more quickly. And it is kind of very similar to what we might have referred to, or we still refer to as a curbside, consultation, because it's meant to be when the patient is still, sort of in the office, and it's meant to be kind of like on the fly, as opposed to a really like a formal, sort of presentation with record exchanges and things like that. That would be nice. We could do better telephone consultations if we had access to the record and we have all the history that we want, but it's just not practical. Some states do design their systems to do things more formally, but we've kind of felt strongly that we wanted them to be these small kind of teachable moments, and to have as many of them as possible. And we actually have thousands and thousands of them. So we we generally have about 15,000 telephone consultations per year. Next slide, please. So the face-to-face consultations are, when we can't answer the question, because we don't know enough and because the pediatrician needs, sort of our help more than just a question, So we do this for clarifying diagnosis, for second opinions, sometimes to improve the confidence. Like a pediatrician might ask me, so what should I do as far as prescribing an SSRI, for example? And I'll ask them how they know the patient has depression, and they'll tell me, that they've evaluated the patient, and I may be entirely satisfied with all the history that they've gathered and feel like they're, right on the right track. But in the beginning of the program, when I'm first getting to know them, they actually may benefit a lot from having a face-to-face to get like a confirmatory consultation, which really sort of helps their learning process to give them more confidence. If they have their own impression, then I have my impression, and then they see that their impression was correct. And we like to get the letters out really quickly within 48 hours. Next, and we do. Next slide, please. So I mentioned this before, but the main reason is, that we do a face-to-face evaluation is if we can't answer the question, or if the PCP really wants it. We might not agree with it, but the PCP really kind of feels like they need us to see the patient, so we won't kind of question that too much. But we have to make sure that the PCP is willing and that we agree that it's appropriate for the PCP to kind of be responsible for the management of the patient. So if this is a very complicated patient that really needs to be seen by a child psychiatrist for care and not consultation, then we won't even do a face-to-face evaluation, because that's sort of, redundant, that we're going to, shift into like a care coordination resource navigation mode to get that patient into specialty care. So the consultations are meant to support, what the pediatrician is going to be doing, as opposed to just to evaluate the patient because they need an evaluation. Next slide. I think I talked about this enough, but the resource and referral piece is a very important part of the program, because oftentimes, it's all well and good for them to know what the patient needs and to have our opinion about that. But a lot of times, some of the biggest problem is, okay, that's great. I know the patient needs CBT, but I don't know how to get CBT for my patient, and I don't know where to find that. And so having that resource navigation piece is critical. And the next slide will show that we think of this as a three-legged stool, if you will. So if you can go on to the next slide. Yeah. So the resource and referral, the telephone consultation, the direct face-to-face evaluation, that all kind of interacts, that it makes the program able to help almost all the time when pediatricians have a question. That if you miss one of those legs, then you might leave the pediatrician high and dry, in the sense that you've answered the question, but you really are not sort of going the distance, and they're still feeling like they're sort of helpless and not able to do what needs to be done. And so that's one of the reasons why we kind of feel like it's so important for programs to include all those components. Next slide. Training education is these are the different kinds of modalities of training and education we provide. I think our most popular offering in terms of training is our monthly webinar. We have a good regular attendance among PCPs, and so over time, they get a lot of content through that, and they also have almost like an Echo sort of experience in a way. I don't know how much experience people have with Project Echo, but that's another sort of approach to education for primary care providers in different specialty areas, where there's kind of a whole group, that's stable, and they get to know each other, and they provide peer support, and they get lots of, sort of content as well as discussion time, with experts. So we have a version of that, but we call it the clinical conversations session, which we do monthly, but there's other kinds too. Next slide. So I just wanted to show this slide just to say that when you're looking at the evaluation, and the consideration of the effectiveness of this kind of program, again, it's important to acknowledge it's not a treatment, so you can't necessarily measure, efficacy. So if it's not a treatment, then, in terms of efficacy, in terms of clinical outcomes, if you're, examining or studying, the efficacy of a treatment, then you can do a randomized controlled trial, and you can have systematic, assessments and really answer the question, as far as whether the treatment works or not. But MPAP is not a treatment. CPAPs are not a treatment. They're sort of more of a system for trying to ensure that people receive treatment. That's not to say that we can't assess the effectiveness of the program model at meeting its goals. And I've already said that the program is really designed to improve access to care and to promote more kind of stable and sustainable relationships between pediatricians, pediatric primary care providers, and specialists, and those kinds of things. And so these are the different domains that have been studied for MCPAP, in terms of, how people feel about the service, how well it's accepted, how well it's utilized, whether it's thought to be appropriate, how feasible is it? We can measure fidelity to whatever the, model of the program is. We can measure some cost sort of impacts of the program compared to usual care, and then different measures of utilization and things like that. Next slide, please. So we've sort of used this, over the years to describe the impact of the program on pediatricians' kind of experience, providing mental health services in primary care. And sort of the most important one of these lines, I think, is the green line, in the sense the pediatrician is reporting that they're able to really meet the needs of kids with psychiatric problems after the program started. And it's been stable. It's been kind of a flat line. We've continued to measure this for years, as well as just different aspects of the service delivery of the program being reliable, being useful. As you will see, that there really isn't much change in perceptions of access to child psychiatry, because that question, kind of when it's asked, in more words, is really about, access to traditional child psychiatry. And because this program is not really offering access to traditional child, if anything, it's almost like limiting access to traditional child psychiatrists, because we've taken child psychiatrists off of the workforce of providing traditional care to do this. And we're also, we're trying to triage, patients and figure out which patients really need traditional child psychiatry care versus which patients can be adequately cared for by the pediatrician with our help. And so as you can see, the program really hasn't, sort of affected change in access to child psychiatry if you define it as more traditional. Next slide, please. So this is just an example of some of that change in efficacy, or the perception of the efficacy among the pediatricians. So as you can see, I don't have the baseline data on this slide, but the agreement, with the notion that they're comfortable treating patients with mild to moderate depression, that's very robust, that we have, pretty significant levels of comfort in the green bars across all the teams of our program, particularly all the pediatricians and pediatric primary care providers who are served by the teams within our program. And the baselines were very low. I should have included that in the slide, but they were really kind of in the 10 to 15%. Next slide. So the same is true for ADHD, for anxiety disorders, not so much for substance use disorders. And I'm going to talk about that a little bit at the end, towards the end, because we have a new approach to that. Next slide, please. So one of the limitations of the program, which I think will be apparent, from this slide, is that there's a lot of variation in terms of how much providers utilize the program. And because the program is requires that sort of initiative of the primary care provider to call the hotline, then you pretty much have some practices that hardly ever call us, and then some practices that call us every day, pretty much. And so I would say that we would want this to be flipped, where we had sort of the majority of practices, using us, sort of a lot, because that's when we provide the best care. And we presume that these practices all have generally similar degrees of need, in terms of mental health morbidity in their practice. But we still have, so I would say, 52% of the practices really call us not frequently, and then we have a small group that calls us more than 100 times per quarter, and then we have sort of a nice moderate group of 33, which is pretty good. But we have a lot of practices we're not touching, and I think that's the reason why we need to think a little bit more about this model, the design of the model, in the sense that people have to, we have to wait for the call. That we've been thinking a lot more about trying to figure out ways to make the program more proactive. And I think that's kind of the need for that is reflected in this particular slide. Next slide. And so another aspect of evaluation is really looking at parent experience. And this was a study that we conducted a couple of years ago, and published last year. And so we did find that parents, this program is delivered, without kind of direct involvement of the parent. So when the PCP calls for a consult and has a curbside conversation, the parent isn't always sort of involved in that. It's kind of we're trying to support the PCP and give them this relationship. It's for the benefit of the patient, but the parent is not always in the loop. But fortunately, and we were really curious about this, we found that parents, were very satisfied with this whole process, that the vast majority of patients knew about it. So it wasn't as if they weren't even aware. And that they were pleased to know that their pediatrician, their primary care provider, was actually working with this program. And this particular sample are people who received telephone consultations, or whose PCPs utilize telephone consultation without our seeing the patient for a face-to-face. So we found that the vast majority, were aware and were very satisfied with that. And we also looked at the role of the pediatrician. We wanted to find out, how do parents feel about the pediatrician's role in being a mental health provider, even though they're, a generalist. And we actually found very, very nice rates of satisfaction among parents with the PCP's overall care. Next slide. I'm going to skip over this data because time is always flowing more quickly. Next slide again. Yeah, I think I described this particular. It's in the handout if you want to see that more detail, and the paper reference is there too. I want to talk a little bit about implementation. One of the implementation issues is, how do you figure out which child psychiatrists, should be doing this work? And we've found that there are child psychiatrists who are really good at this, and there are some who don't do as well. And the ones who are really good at it for recruitment for these programs are ones who are very gregarious, and ones who are flexible and not particularly fussy, because it's sort of, the work is not for the faint of heart, if you will. It's a little scary. It's almost like practicing child psychiatry, or it's like being a pilot, and flying without a visual. You're sort of flying on controls. It's a higher level of piloting, and certification to be able to fly in a storm when you can't see, what's going on and where you are. And that's kind of what it's like in a way. Now, I will say, because it really has more of an educational kind of quality to it, that you're not, treating the patient, by remote control, but you are helping, sort of the pediatrician and teaching them, by remote control in the sense that you're not seeing the patient. So you have to kind of be able to, be flexible. There's some risk tolerance involved, that goes into the confidence. And then, people really appreciate when we're very practical as opposed to being very theoretical and very kind of heady, that we find that these conversations go much better when we make sure that we give them lots of very succinct, practical advice, that we're not ponderous, in a sense. And some child psychiatrists are, and I think they have their value in different contexts, but not so much for CPAPs. Next slide, please. Yeah, so I kind of said that. Next slide. Yeah, people worry sometimes that these programs are going to overwhelm their clinics, but one of the things that's really important is that we create boundaries, between a regular specialty clinic and the staffing of these programs, just so that patients don't get the message that they're being denied kind of follow-up, by the child psychiatrist, when they come in for the face-to-face. Sort of they're coming into a specialized program that only does consultation, and they don't have to kind of say, why am I not getting a regular appointment like these other people in the waiting room? And so it's structured, and it's not terribly stressful to field these calls when you're on duty, to do this kind of work. So it has to be structured so that people have protected time to do it. Next slide. All right, I'm going to skip over this next one, and if you could go on to slide 38. So one of the things about CPAPs and the PAP that's, I think, the biggest performance variable is kind of how well we're able to engage. So if we go, with what I said before, as far as the CPAP is really meant to build, relationships, and so engagement, is the word of the day. And because telephone consultation is the majority of all the encounters, and it's really the front end of the program, we really want very badly for those telephone calls to be satisfying in the moment, to the pediatricians. And so we want them to feel like they're getting what they need. And we want them to feel that we're taking into consideration their own uniqueness as providers. And so we don't have a one-size-fits-all approach to the pediatricians. We sort of give them different things depending upon where they are in their journey, in terms of, doing this work. We really want it to be efficient. So again, we want it to be a short, conversation. We want to be very mindful. If the pediatrician tells us that they have more time, then we'll be more, expansive. But sometimes we have to read that, in terms of the tone of voice and the character and the nature of the interaction. So we have to be sort of responsive and sensitive to that. And ultimately, we're trying to build trust. So we want people to know. Some of it has to do with just operations of the program, is making sure that the trains are running on time, that the hotline is staffed and answered, and all these little things seem very mundane, and they are mundane, but they have a very powerful influence on engagement. Because if someone calls and they don't get a live person and they leave a message and nobody calls them back for a couple of days and they had something going on that was more kind of urgent, then it's going to be really bad, for the relationship, and they might even tell their friends, and not call. So a lot of the programs that provide this model, they either are successful or not, depending upon how well they sort of handle this whole engagement, sort of function. Next slide. This is an example of treatment algorithms. I referred to this when we were talking about the patient in the beginning. but we, and you can't read all this, but we did a lot of work to really establish consensus, because we have 28 different child psychiatrists, and we don't want people getting different, recommendations, too much. If they happen to call one day on a patient and have a similar kind of question another day, it ends up making them confused. And so we did the work to do this for ourselves, in part, because we wanted to be aligned, as a program in terms of, certain beliefs, and views as far as, best practices. And we also use them as a tool for the pediatricians, so that we teach to these algorithms. We provide them to PCPs. We refer to them when we do telephone consultations, and we kind of remind them about the fact that they exist. And so we have a whole set of these algorithms. And we also have a companion document called Clinical Pearls that goes into a little bit more detail and more sort of narrative. These guidelines are much more kind of referencey, sort of, handbook style sort of recommendations, whereas the Clinical Pearls are a little bit more narrative. Go on. Next slide, please. So I mentioned this issue about the fact that MCPAP and CPAPs are a sort of an on-demand, kind of program, or, the notion of pull versus push. So if we did outreach, and if we kind of, called the pediatrician and said, I heard that you had this, patient who needed some help, and here's what we recommend. That would be push, and pull is when we're kind of sitting around waiting for people to, call the hotline. And so there's changes in pediatricians' motivation. There are differences in workflow for practices. So these are some of the challenges that we face. I mentioned a couple of bullets here about geographic versus network model. We were kind of worrying about this more a couple of years ago, when practices were kind of banding together, that there was a big movement to have practices join networks, and networks all had their own sort of population health strategy. And so we started to wonder, should we still be a geographic program, or should we sort of try to work with networks, some of which crossed, geographic lines, and try to build relationships with networks? And the answer is that it's both, that we have to do both, because the world has changed since we started the program in 2004, and we're not just dealing with individual, practices and small businesses. We're dealing with large networks, and we have to be aligned, with the goals of those networks, but we also have to meet the needs of the individual practice in a particular region. So we have, figured out a way to honor both in our kind of our functioning. And this notion of this, the last bullet goes back to the point I made about the different types of collaboration and integration. And they really are not, mutually exclusive. And so sometimes there's a perception, that, if we have a CPAP, that means we can't do this, or if we have an embedded clinician, it means we can't use our CPAP. And the answer is that embedded clinicians can call the CPAP. And actually, it's really good when they do, and when they do, actually, we find ourselves functioning more like the collaborative care model, as opposed to, sort of just a CPAP. Next slide, please. So one of our biggest initiatives in terms of trying to improve and evolve as a program is really to try to marry, the standard CPAP activities of telephone consultation with the embedded therapy, that's come into existence really in the last, decade, where we have so many more embedded therapists. And so we've actually conceptualized this as almost like an adaptation of the collaborative care model. So the standard collaborative care model is you have a consulting psychiatrist, who has a relationship with a practice, and they meet every week, with the embedded therapist, who has a caseload of patients, and they're doing measurement, with those cases. And so every week the child psychiatrist kind of has a meeting with the therapist, and they go over the registry of all the cases that they're treating, They look at the measures, they talk about how the patients are doing. And then when they identify patients who are not doing well, then the psychiatrist helps to generate recommendations as far as what to do to try to optimize the care and to try to turn things around and get things on track. And a lot of times that involves recommendations to the PCP for prescribing medications. Some of it involves, just talking about the formulation and trying to think about the differential therapeutics together with the therapist. But that's the standard collaborative care model, whereas the CPAP version of that, would be that the telephone consultant who's on duty on a given day might sort of have a couple of meetings during their day with embedded therapists. And instead of waiting for them to call, they would sort of have a regular meeting with them and go over their cases, ideally on a registry, but however. And then once, they identify patients who are not doing well, then instead of waiting for the pediatrician to call with a question, the child psychiatrist would call the pediatrician and say, I was talking to your therapist about Johnny, and we were talking about how he was struggling right now and not making progress in his treatment. And I would recommend that you consider prescribing an SSRI, or you might even say, I would recommend, instead of recommending, I just wanted to let you know that some of the best practice standards that we embrace in child psychiatry include, stepping up to an SSRI to add that to the therapy if the patient's not getting better. And I'd be glad to help you with that if you're interested in doing that. And so that would be sort of turning the whole model of MCPAP upside down for that particular patient. But we've done that, and we've piloted that model, and it's pretty exciting. Actually, in some ways, it's kind of a game changer, for the way the program works. And it actually is very, very well received too. We were concerned initially that the pediatricians might, be offended if they got sort of a call out of left field from us asking them to do something that they weren't asking for help on. But it seems to work very well. And so the biggest challenge was that it's funding, really, because we don't have enough staff to do this kind of on a regular basis with everybody. But it is it's something that we want to do, and we're trying to develop some funding strategies to do that. So the last point that I want to make is really just that we've been able to create spinoffs of MCPAP in Massachusetts. And so if you go to, actually, can you go on to the next slide? And so this is MCPAP for Moms, which is focused on perinatal depression. And if you go on to the last slide, slide number 44, there you go. This MCPAP for Moms was the first spinoff, but we've spun off autism spectrum disorder version of MCPAP, which is part of MCPAP, but it's just kind of a specialty team that we can direct, certain technical questions about, treatment planning for autistic children. We have ASAP MCPAP, which is a substance abuse counseling, which we were providing through telehealth for patients in the primary care setting. MCSTAP is basically an adult substance abuse treatment, substance use disorder treatment consultation program. And then we just got a HRSA grant to do an early childhood version of MCPAP, which will be kind of like a plug-in as opposed to a spinoff. The ASD, the substance use, and the early childhood are really more plug-ins to MCPAP. And then the substance abuse one, MCPAP for Moms, that's more of a spin-off, if you will, because it's a different population and has different staffing. So I'm going to leave it there. I'm going to stop, and I thank you all for your attention. I'm sorry that I didn't leave more time for questions, but I would be glad to answer any questions as best as I can in the last few minutes.
Thank you so much. That was extraordinary talk and extraordinary work. I do have a question. How do you get people paid? So you have folks from, I understand you get dollars from Department of Public Health in Massachusetts, and you're on private insurance, but then you have docs from various hospitals. So how do you manage that?
Yeah. Great question. And the answer is pretty simple. So our program is it's cost-based reimbursement of all the teams by the state. It does go through a fiscal intermediary. So there's kind of a management company that takes the money from the state and then pays the teams. But we pretty much procure the service from the nonprofit sort of academic sector by the state. So it's a procured service. So there's really no fee-for-service reimbursement. There is some fee-for-service billing that ends up offsetting the cost of the program, but everybody works for MCPAPA on salary with an institution, with a hospital or an academic medical center or medical school, and they're pretty much just on salary. Now we do get, you didn't ask this particularly, but the funding of the program is something that comes from a blending of both private and sort of public, state-funded dollars. There's no Medicaid reimbursement because we don't have a waiver for that, but we do get money from the commercial insurance companies, and that's through legislation. We actually got legislation passed to force them to help pay for the program because they were benefiting from it, and they didn't want to contribute. So that's kind of the answer.
Thank you. We have.
So sorry.
Go ahead. Go ahead, Catherine. Go ahead.
Just a quick question. Thank you. This presentation is fascinating, and I'm wondering how you see this model of consultation in relationship to the future of integrated behavioral health. For instance, is the goal to have more services like yours that regional clinics can tap into, or do you see your program as more developing the skills of primary care clinicians to be able to take on that child psychiatry role for prescribing?
Yeah, I think sort of both. Catherine, the vision is really that every state in the country will have these regional teams, and that they'll be available as regional resources to all the practices within the geographic catchment area. And then we also want practices to have integrated behavioral health clinicians. But because the vast majority of integrated behavioral health kind of implementations are with therapists, master's level therapists and psychologists as well, we feel like this regional sort of delivery system for the psychiatric piece of the integration really sort of is better to be kind of configured this way as opposed to kind of in the embedded, kind of practice setting. And we kind of feel like it needs to be kind of organized just because it's more of a scarce resource, and it's a very expensive, it's the most expensive resource too. So we kind of feel like that. I feel that would be the ideal system for every practice to have integrated behavioral health clinicians working, directly with the teams, and for every practice and every integration sort of, implementation to be able to utilize child psychiatry resources through their regional CPAP, if that answers your question.
Well, you gave us a lot to think about. I'm still on the money train, though. So folks are, they have their regular positions at their academic medical centers. So this is like on top of, so they get to like sign up for, or it's just part of their salaried work.
Yeah. So the child psychiatrists in particular, they have their regular job. They teach, they have clinic, they do research and other things. But anybody who's participating in this program, needs to be supported, with protected time. So it's not just an add-on. And so that's why the program needs to be funded. So we have the funding to be able to pay all the departments of psychiatry, in all the institutions, so that they can sort of, take them off out of clinic, or sort of be able to support and protect a chunk of their time to do MCPAP duties. And so it's critical because a lot of times the way it works in departments is that people are always asked to do more, and they're never kind of necessarily, nobody thinks about how much time it takes, and well, people do think about it, but they might not be able to do anything about it. And so money doesn't, it's not clear where the money is going, and so MCPAP actually has had to, police this a bit, because sometimes we'll notice that the response times to calls are too long in a certain sort of institution, and we'll find out that they had a coverage problem, and the person who was supposed to be on duty for MCPAP was covering the inpatient unit. And so there's a lot of need, because it has to be so responsive, so it's not something you can just do at the end of the day, that you need to kind of be at your post, if you will, to get the call from the pediatrician and to see them or to talk to them. And so that's a challenge, I think, in a lot of departments, and we have to constantly sort of keep an eye on it. And nobody's trying to cheat anybody. It's really just because things are hard, and people get sick and they have to cover each other, and it can be tough. But we don't want to be like the last priority, in the department.
I appreciate your honesty about that. So we are past our time. Thank you for staying over, everyone, and to you especially, Dr. Sarvet. It was a pleasure hearing about the work that you do, and it is a great model for us in the state of California. We rank 48th in the nation in providing quality mental health services to children, for in all other various indices. So it is a model to admire. So thank you very, very much. And everyone, take care, stay safe, healthy, take care, have a good rest of your afternoon.
Thanks so much for having me. I appreciate it. Good luck to everybody. Yep.